you very much for inviting me. I'm Xavier. I'm a family physician based in the city of Barcelona. I'm actually doing primary care clinic in one facility and a group practice. We are covering a total of 50,000 citizens of the city of Barcelona in one part of the city. And we are totally working 38 GPs in the same building, together working with nurses. So now, besides doing clinic once a week, I'm working for the government in Catalonia, advising the government in terms of innovation and research for all the healthcare system, not just primary care. But I still doing clinic in primary care once a week in diabetes. So my talk is trying to put in context how we have to understand the added value of adding or considering SGLT2 inhibitors as early initiation in the management of diabetes as a cardio-renal protection. Besides, I didn't mention that, but I'm the chair of a non-profit organization called Primary Care Diabetes in Europe. So I have the honor to chair that NPO. So this is the agenda suggested for the next minutes. I'm going to talk about early treatment in type 2. I think probably it's more logical to do this lecture after Professor Kunti once, because he's going to talk about the benefits of early treatment, early intervention. But I'm going to manage a little bit about early treatment in type 2 diabetes management, cardiorenal metabolic links, benefit of SGLT2 in beyond glycemic control. What is said now, probably the most well-known guideline, it is the ADA-ESD one, and what are the next challenges? So related to early treatment in type 2, this is the traditional scheme. This is as a narrative review, really just published in January this year. And that tried to project the two traditional schemes. This traditional scheme that it was trained to treat under the treat to fail. And then, of course, that is the traditional one. But then we move to the new way of operating in terms we have to be more intense in terms of the management. We need to be trying to be doing a more tight approach and just trying to avoid a worsening on the A1C. And this is the scheme that now is recommended, being tighter and trying to be more intense and avoid clinical inertia. But what we have to do in terms to do that, we have to be also trying to consider like starting with monotherapy, starting with double therapy. We have already some evidence on that. It was a trial with a compound I think is very well known in India, that is vildagliptin, that it was the verified trial. The verified trial, it was the first trial that has been done in trying to test if 2 is better than 1. Okay, and that it was a study that it was done for 5 years, trying to see the impact of this combination compared with just one standalone metformin or vildagliptin or combination. So combination, it projects a better impact in terms of progression of the disease, and that was published in 2019. But of course, when we have to consider to add a second compound, and which one would be a good one to add in terms of cardiorenal protection. In that case, I invite you to consider this idea of these chronic conditions that we can observe in terms of any person living with diabetes. It will cardio consequences and renal consequences. And we know that ones that have type 2 diabetes, and they also could have at least 40% some kind of renal impairment. Okay, and sometimes this is not really well detected, and I think also it's important. And yesterday I was talking about this in the course that is doing here in the first floor about the importance of testing our citizens living with diabetes to test the function with AGFR estimation and the damage, trying to estimate the ratio, the albumin-creatinine ratio. That is very important in terms to know in what situation, in what status of the kidney they are. Also, we know that in terms of in those persons living with diabetes, also a higher risk of having heart failure. This is no more well known, okay? But of course, having access to techniques like echocardiography, sonograms, and also exploring in that patient if have some kind of symptoms that allow us to alert to have this problem, we have to know that around is a big proportion of them that have also these problems. And we know that between 20 to 40% of them have heart failure in living with type 2 diabetes. Of course, if we also see the combination of CKD and heart failure, we also know that up to 60% of people with CKD also have cardiovascular disease, and between 30 to 40% with heart failure have CKD. So it's a niche, it's a connection between the metabolic, the kidney, and the heart. And of course, we know that when everything is combined, we know that we have this higher risk of having heart failure combined with type 2 and CKD in around 16% of our individuals. So this is very important. And it's very important in terms to understand, and sometimes it's important to early screening. That's why I talk about the idea of doing the albumin-creatinine ratio, estimation of the filtration rate, that allow us to stratify the risk, because not everybody living with type 2 is equal, is the same. We need to put our efforts in more intensity in those ones that are a higher risk of complications. And we know that those ones with microalbuminuria, with eGFR decline are higher risk. So we need to do early screening, diagnosis, and if we do those things, it's because we have a solution. I always think in an example. What is the reason to do screening in mammography in terms of breast cancer? It's because we have solutions. We have chemotherapy, we have a surgery, we have approaches. Where we are doing screening and diagnosis is because we have solutions. We have medications, we have approaches. We need to be more tight in blood pressure monitoring and in the medications we are using to reach some targets in terms of lipids, in metabolic control. So, of course, early screening, early diagnosis, but please, early intervention and action, whatever, from lifestyle to the medication that could be needed, okay? So it's also important that one in terms of guideline recommendations. And what are recommending guidelines? Multifactorial approach. When we are in front of a high-risk individual, we need to be focused completely in the cardiovascular risks and also trying to reach the target on those ones. Of course, here we have what would be benefits or other sites where we can observe benefits of these compounds, SGLT2, besides the metabolic control. And we know there are other locations besides being a medication with benefits in terms of metabolic control. And we can have here in a more clear manner, we know that compounds, SGLT2 inhibitors, dapagliflozin, empagliflozin, canagliflozin, all of these families have this impact, anti-inflammatory effects, anti-fibrotic effects, endothelin protective, also reduction of blood pressure or adiposity and weight, and also tubuloprotective. And the mechanism that sometimes is not still clear, his hypothesis about why is kidney protection, but it's clear that have impact also in the kidney. Here I'm going to project you what has been when you have any new compound, and you know now from 2010, any new compound to be on the market requires some safety studies. And of course, that happens to all the family of the glyphosomes. I mean, canagliflozin, empagliflozin, all of them requires these cardiovascular and outcome trials. But on those, all of them were designed for non-inferiority. It means they are not damaging, but also to demonstrate if they compounds could provide benefit. And it's clear in the first row that compounds project benefit in terms of what it was the principal indicator, that it was cardiovascular death and myocardial infarction and stroke. And I think that is important to keep in mind. For the first time, and that was demonstrated in 2015, a compound that it was thought and use it for diabetes management were observing benefits in terms of cardiovascular impact. Also, the studies also have other parameters to be studied, secondary objectives, and that ones start to provide a flavor of it was benefits in other sites, in the heart and in the kidney, and that was generating hypotheses and the potential benefit of that compounds in the kidney and also in the heart. So that's why it's the reason that beyond that benefits in the metabolic control, that that studies suggest hypotheses to start designing new projects. And these new trials, like the Emperor Reduce, trying to demonstrate if this, in that case, empagliflozin was beneficial in persons with a low ejection fraction, okay, was observing a benefit in 25% reduction on those subjects. Also, in those ones we have have a good ejection fraction, in those ones with heart failure with preserved ejection fraction, also benefits of 21% in case of that study, the Emperor Preserve, in case they were using empagliflozin. If we are observing trials in terms of diabetes kidney disease that it was projected on the cardiovascular and outcome trials, it was similar impact. They also, you can see because the big trials in terms of gliflozins and is EMPA-KIDNEY in case of empagliflozin, Credence trial in terms of canagliflozin, and DAPA-CKD in terms of dapagliflozin. The three trials project benefits. So this idea of kidney protection is sustained. Now I'm going to project some information, and this is data from the EMPA-KIDNEY trial observing a 28% reduction in terms of events when we compare those individuals on that medication compared with those ones without empagliflozin. The same happens in the Credence trial. Also, we observe this benefit in terms of 30% reduction in those individuals that were on medication compared with those ones that not. So that also reinforced what it was observed on the cardiovascular outcome trials. They just start announcing this medication could be beneficial in the kidney with kidney protection. This medication could be beneficial in the heart. And now you know that medications are approved to be used in persons living without diabetes but having heart failure or having chronic kidney disease, not without diabetes. So the benefits of that medications, it's clear. So now, and just to approaching the end, where is recommended? The guidelines always are trying to position it the best evidence in place, just to help us and coach us where these compounds need to be considered. And of course, I just amplify that figure, and you can see here that in that place where you can see you have those previous cardiovascular disease, you have heart failure, and you have chronic kidney disease. And the first compound recommended after is SGLT2 inhibitors after metformin. So you think to consider when you have an individual living with diabetes with that situations, that due to the benefits of that compound is the first compound recommended to be used for the benefits that has been projected on the trials I already mentioned. So as a summary, I think what are the next challenges? And I think it's important to keep in mind that some of these trials sometimes is just reduced in terms of time. We need to go for an observation period. No, in terms of diabetes and early therapy, early approach, if all the individuals have benefit of this early approach. It's supposed that it happens, but there's not any trial that has been, except the Verify, trying to use vildagliptin and metformin, the benefit of starting early in the therapy, in a good design, 5 years, and in the other compounds, we have to be waiting probably with real-world data. And that real-world data is going to provide us information about safety, information about side effects, but clear information about how critical is to incorporate medications that are disease modifiable, I mean, medications that have impact in the kidney or have impact in the heart, together with an holistic approach of all the risk factors in terms of benefits in reducing events on that persons. So thank you very much for your attention.